Hey guys, we've had a few interesting cardiac cases over the past year since I've started, and what I want to do is every few months do just a short EKG review because they are interesting cases and we don't get to see a lot of EKGs in the field, or at least pathological EKGs. So you really need to look at a lot of EKGs to get better at interpreting them. These cases have been redacted to protect the patient and the provider, so there's no need to worry about that. We're going to discuss quite a few things during this segment. We're going to talk about the difference between STEMI and non-STEMI, reciprocal changes. We'll talk briefly about the STEMI criteria, talk about the role of proportionality, and we'll talk about what you do if you have a EKG that you're concerned about but that does not meet the strict millimeter criteria. So what's the difference between a STEMI and a non-STEMI? Well, as you know, so a STEMI is a patient that has EKG changes indicative of a STEMI with or without troponin changes. An in-STEMI is a patient who doesn't have any EKG changes that are diagnostic for STEMI, but they have a positive troponin. So the interesting thing about in-STEMI is that a lot of times when these patients are cath the next day, they usually try to take them to the cath lab within 24 hours if they don't have EKG changes, but the troponin's positive. But about 25% of those patients who are deemed an in-STEMI have a coronary occlusion the next day when they perform the cath lab. So it's quite possible that these patients did have some EKG changes that just weren't appreciated by whoever was interpreting the EKG. Now, you all are probably familiar with STEMI criteria. This is very confusing, and I frequently forget it, to be honest. And I bet that if you were honest with yourself, you probably didn't know what the STEMI criteria was for men and female, less than or greater than 40. A lot of people just say it's 2 for everybody, but that's actually not what the definition is. So it depends on the age and it depends on the gender. I don't want to talk much about millimeter criteria because I believe the best way to interpret an EKG is based on patterns. And speaking of patterns, you're probably familiar with contiguous leads. And if you're confused about what contiguous means, if we talk about contiguous counties, so for Jessamine County, if we said what counties are contiguous with Jessamine counties, well, it would just be all of the surrounding counties. Where we're looking at a specific geographical location. Well, when we're talking about contiguous leads with an EKG, we're talking about leads that are looking at a specific anatomical location on the heart. So you can see 2, 3 in AVF, they look at the inferior wall of the heart, 1 in AVL looks at the lateral wall, these look at the septal, then V3, V4 anterior, and you probably already knew this. It helps to think of the leads as cameras. So imagine that there's a camera looking at a specific part of the heart. If V2 was a camera lens, it would be shooting the septal wall or anterior wall of the heart and so forth. Reciprocal leads are probably some of the most important changes that you can appreciate on an EKG. So if you take my previous analogy, the camera analogy, and you say, okay, if we're looking at lead 3, okay, that's what the camera is looking at. Now, directly behind that, what vector or angle are you looking from? And then you would almost be looking from AVL. So lead 3 and AVL are almost directly opposite of each other. So if you see a change in lead 3, you expect the opposite to happen in AVL. If you see a change in AVL, if you see ST elevation in AVL, what do you expect is going to happen in lead 3? Or you expect there to be ST depression. So just think of reciprocal leads as the opposite, leads that are directly opposite of the other lead. Now, in the anterior leads, it says that reciprocal changes are 2, 3, and AVF, but the interesting thing about the anterior leads is that sometimes you can have a STEMI or ST elevation in the anterior leads without having any reciprocal changes in the inferior leads. So one thing I want to point out about reciprocal changes in the inferior leads or the high lateral leads and vice versa is that in lead 3 and AVL, they are almost directly opposite. In fact, they're opposite of each other pretty much more than any other leads on the standard 12 lead EKG. So if you get a change in one, you will get a change in the other. Meaning, if you have elevation in 3, as a rule, you will have depression in AVL and vice versa. Now, what about the posterior leads? Let's ignore this one and let's ignore septal for now. What about the posterior? Section of the heart? Well, we don't have any leads on a standard 12 lead that looks at the backside of the heart. So what are we looking for to clue us in that we're having a posterior MI? Well, we look for depression or ischemia. They call it ischemia, but what it really is, most likely, is reciprocal changes to the posterior MI. And we're going to look at a few cases. So on case review 1, this is a pretty obvious inferior MI. I don't think anyone would miss this. This is quite obvious. The computer picked it up, and we would pick that up too. But what do you see? You see obvious ST elevation in the inferior leads. You see reciprocal changes in AVL. I want you to also look at the morphology of the ST elevation. Dr. Amol Mattu refers to this as the checkmark sign, kind of the Nike symbol. So the ST segment has straightened out. This is a common morphology that you will see in STEMIs, and sometimes it's the first thing that you see before you see any ST elevation. You will see this ST segment straighten out. Now remember, we said that the rule is that if you have elevation in 3, you will have depression in AVL. Sometimes, and actually probably more than sometimes, quite frequently, you will see ST depression in AVL before you see any obvious elevation in lead 3. Now looking at the precordial leads, V1, V2, V3, and we'll get to V4 here in a second. But what do you see in V2? You should say depression. You see depression in V2. Now this is reciprocal, or most likely reciprocal, to a posterior MI. The great thing about posterior MIs is that they rarely occur in isolation. It's more common to have an inferior and posterior STEMI. So this is not anterior ischemia, it's reciprocal changes to a posterior STEMI. Now, why is there ST elevation in V4? You wouldn't expect to have depression, normal, elevation, normal. That kind of stands out like a sore thumb. What this is, most likely, is that they took V4 and moved it to the right side. So this confirms that there is right ventricular involvement. So all you have to do is take V4 from your standard frontal 12 lead placement and move it to the same anatomical location, the same rib space, just on the right side. This seems like a fairly normal EKG. The interesting thing about this patient was that they were having classic signs and symptoms of ACS. So nothing really stood out. So nothing really stands out on this EKG right away. But what did the paramedic do? They kept obtaining EKGs. They repeated it, and then finally they got this EKG. So this EKG clinches that diagnosis and confirms what the patient was already telling them and what they already thought was going on. This is why it's important to get serial EKG tracings. So I want to pause for just a second, and I want to give you some time to look at this EKG. Based on what we've talked about, what do you think is wrong with this patient? Well, we see a sinus rhythm. There's P waves for every QRS. The QRS is less than 0.12 seconds, so it's not wide enough to be a bundle branch block. We see some elevation in the inferior leads. Now remember, the J point is about right here, okay? And that's the junction from between where the QRS ends and the ST segment begins. This is the J point. If we draw a straight line down, we'll see that the J point is about right here. So it's clear that there's about 1 millimeter of elevation, and that's probably what has triggered the computer to give this interpretation. I also want you to note that there is inverted T waves in AVL. So if you're ever unsure if this is an inferior STEMI or not, look at AVL. If there's ST depression or flip T waves, then that confirms what you were thinking. Now, if you look at V3, you'll see some ST depression. Remember, inferior and posterior MIs go hand in hand. So if you're still not sure, even though you've seen reciprocal changes in AVL, if you see anterior ST depression, then the diagnosis is obvious. Here's another case. I think what makes this case difficult is that there are a lot of PVCs. And when there's a lot of PVCs, it can distract you from what's really going on. There's some elevation in lead 3 that's really difficult to appreciate. But if you look at AVL, don't look at the PVC, but look at the native normal beats, there is massive ST depression. Now, this is not ischemia in AVL or lead 1. This is reciprocal changes to an inferior MI. Now, the monitor did not pick up on this because there's not a lot of elevation. But look at this T wave. So the EKG is proportional. If you have a massive T wave and a small QRS, then that T wave is disproportionate to the QRS. It's not normal to have a massive T wave and a small QRS. If you've got a tiny QRS, you should expect a small T wave. So these T waves are what's referred to as hyperacute. Even though they don't look that tall in isolation, if you compare them to the QRS, you see that they are tall. Now, if we're still not sure about whether or not this is an inferior MI or early changes for an inferior MI, well, we have AVL, reciprocal changes in AVL that kind of tips the scales in favor of an MI, but you also have anterior ST depression. Next case. So this is a seemingly normal EKG. This was the first EKG, and I put these in order. This was a patient that was complaining of classic signs and symptoms of ACS. So what do? One EKG is not enough, and one EKG should always beget another. They got another EKG. You can see the obvious changes. Anytime you have dynamic changes like this, that should confirm that the patient is having an unstable lesion in their heart that needs to be stented. So they have hyperacute T waves because that T wave is as tall as the QRS complex. And remember that the EKG is proportional. Not only that, but you have anterior ST depression. You have a tall R wave and ST depression with a terminal upright T wave. This is classic for a posterior STEMI. So what should you do in this case? If you don't really have enough inferior elevation to make you comfortable or confident in calling this a STEMI, but you have this massive ST depression, well, you get a posterior EKG. You take V4, V5, and 6 and put them on the back, on the patient's back. V5 would be right at the tip of the scapula. V4 would be just to the left of that if you're facing the patient. V6 would be to the right of it. Just don't put it on the spine. And then you would print that EKG off, mark V4, V5, and V6, and put V7, V8, and V9. Now, this was the same patient. This was the third EKG. This was after they treated the patient. So you can see the dynamic changes from one to the other. And this EKG was taken less than a minute from the initial. What I want to say about this is one positive EKG, in my opinion, and in the opinion of many cardiologists, is enough. One STEMI positive EKG in a patient who continues to have ischemic chest discomfort needs to go to the cath lab. All right, so what do you do if you have a subtle EKG? After what you know now, you see that you have hyperacute inferior elevation, maybe some anterior depression, and reciprocal changes in AVL. The concern is that you may not be, even if you activate the cath lab, that you may get to the cath lab, the cardiologist will look at the EKG and may send you back to the ER. Well, to put it bluntly, I don't really care. I don't care if you have a false cath lab activation if you feel confident that what you're seeing is a STEMI. The burden of proof should be on them. So if we activate the cath lab, then the burden of proof is on them to prove that it's not a STEMI, and the burden is not on us anymore. The same goes with a computer interpretive statement that says that it's a STEMI. If the computer interpretive statement says that it's a STEMI, then the burden of proof is on us to show that it's not a STEMI. I would much rather get sent back to the ER because they disagreed with me than for the ER physician to look at the EKG and say, oh, this is an obvious inferior STEMI. I don't care too much about false cath lab activations. Now, if we have multiple shift, that's probably a problem, but we shouldn't have that many to begin with. We'll do more training on STEMI mimics in the future. We'll do training on left bundle branch blocks, right bundle branch blocks, left ventricular hypertrophy. But it would be good for you to take the initiative and go ahead and research those EKG findings such as left bundle, LVH, because they are probably the most common STEMI mimics, and they're the most common reasons for a false cath lab activations. Something like this is not common. Now, if you're ever transporting a patient and you have a subtle EKG like this, or maybe even like this, and you're not sure, the best thing to do is get on the phone with an emergency physician at the center that you are taking them to, because they will be the ones that can call the cardiologist and ask the cardiologist what they think or what they want you to do. There have been times where I didn't have the ability to transmit the EKG, but I've explained to the ER physician that they're having, one, classic signs and symptoms of ACS, two, they're having a subtle but real inferior elevation and or hyperacute T waves with reciprocal changes in AVL and some anterior ST depression. And usually after you say that and the ER physician consults with the cardiologist, most of the time they will say bring them on to the cath lab. If you have trouble getting a hold of the emergency physician, then just activate the cath lab. Because millimeter criteria, saying you've got to have 2 in this lead, 1 in this lead, that is pretty arbitrary. It's arbitrarily defined, and it's not based on real good data, because the EKG, the heart, the patient's heart, doesn't care about following millimeter criteria. It doesn't say, well, I'm only going to infarct if I have 2 millimeters or 1 millimeter of elevation. And actually, in 2013, the HA-STEMI guidelines came out and said that hyperacute T waves can be seen often in the early phase of a STEMI. So you wouldn't be wrong if you saw an EKG like this, or like this, or like this, and activated the cath lab. As always, if you ever have any questions, you know how to get a hold of me. I hope that you found this interesting and informative, and I will talk to you next time.